Good morning everyone. My name is Dr. Karan Malhotra and I am currently a Foundation Year 2 doctor at Salford Royal. As I'm sure you're aware, I'm going to be talking to you this morning about the use of the mobile clinical assistants at our trust. From now on I'm going to refer to the mobile clinical assistant as MCA. My plan for this morning is to talk to you for about 15 minutes, and at the end of this we'll show you a short series of video clips lasting about 3 minutes, which have been designed by our phlebotomy department to show you how they have used this to help them. At the end of that, if there's any time, I'll be happy to take any questions. So just to set the scene a little bit, I'd just like to start off by talking a little bit about Salford. We're a tertiary centre and a teaching hospital with links to Manchester and Salford University. We also take referrals from the Northwest for neurosciences and neurosurgery. We have about 320,000 patients a year. Breaking that down, it's about 1,000 outpatients a day, 200 patients in our A&E department a day, 840 inpatients a day, and about 600 patients arriving at our radiology department every day. Now that's quite a large patient turnover. And in order to try and manage the data on these patients efficiently as possible and reduce our workload, we decided to adopt IT and an electronic form of patient records. When we first looked at the MCA and decided to bring it into our trust, we had certain aims for it in mind, certain goals which we wanted it to achieve. These included reducing unnecessary and routine tasks, such as filling out paper forms which often got lost and misplaced. We wanted to help make patient care safer by helping to reduce delays and improving communication between our team members. Also, we had in mind that it would help us to reduce the junior doctors' working hours and help us conform to the European Working Time Directive. Now that's quite a lot for just a single device to achieve, but we decided to see how it would do anyway. But for any successful system, it needs to be based on certain principles and a certain backbone. And for us, that's our electronic patient record. So in order to understand how we use the MCA, I'd just like to give you a brief overview of what our electronic patient record is about. We're trying to do away with paper notes, and all our clinical notes which would traditionally have gone on paper are now entered into a computer software. In addition, all investigation results, all pathology results, and any outpatient letters or letters sent to patients or between specialties all appear on the system as well, and are easily accessible from any point of the hospital at any computer terminal connected to our network. Also, any health issues can be entered for various medical and non-medical and administrative reasons, and patient allergies and other medication entry data can be entered as well. We do our discharge summaries on these as well, including the medications and prescriptions which go through the pharmacy, and all of this is done solely on the computers. We also are running a pilot where we're doing away with our normal drug charts and replacing these by electronic prescribing. So all our medication on certain wards at the moment is prescribed just on computers. We've also recently introduced certain pro formas for clinical pathways. Now, these are akin to sort of flow charts which we have in our system for use by junior doctors. For example, if a patient were to present with chest pain, the junior doctor could pull up this flow chart on the system and make sure that he's gone through everything necessary and required by hospital policy and nationally agreed guidelines. This makes patient care safer and helps provide guidance for junior doctors. Now, with any system, electronic or paper, a number of criteria need to be met. The system needs to be usable and efficient, and must be at least as good, if not better, than the previously existing system. The challenges we faced in our trust were access to laptops and PCs. Now this was a big problem. Since we moved away from paper, there was a high demand for the number of computers, and people couldn't all get on them at the same time. We used laptops to try and have a mobile system. Unfortunately, our trust policy dictates that our laptops be encased in large metal trolleys, which seriously hampers wireless connectivity. The other problem was space on the ward. Laptops in a big trolley take up space in the corridor and can block, and you have to rearrange patient workspace and ward space. At the same time, desktops require office space, desk space, and seating space. A problem with any electronic system is a problem of data entry duplication. Two people on opposite sides of the hospital could be entering data on the same patient simultaneously. And perhaps the biggest challenge we had was the culture of use. For whatever reason, people were hesitant to take to IT, either because they have difficulty typing, they don't trust computers, or they find it difficult to get one or difficult to understand and use. So these are all challenges which we hope the MCA would help us address. And as you can see, that's quite a tall order. But we decided to try these anyway, and starting June 2008, we began a pilot program where we initially trialed these on 4 wards. Now, I was fortunate enough to be on one of the wards with my colleague, Dr. Matt Williams, and we had an opportunity to trial these and feedback to the relevant departments and say what we thought was working and what we thought could be changed and improved on. After about 3 months of trying this, we deployed 2 MCAs to each of our ward. We had 96 units sent to the wards in total. 17 additional units went to our phlebotomy department, which I will talk about a bit later. After using these for 2 months, we had a period of feedback from all our staff, where we got the views which we thought, see what people thought was working well for them and what they thought could be improved on. Over this time, it's been used not only by junior doctors, for whom it was originally intended, but also by nurses, physiotherapists, occupational therapists, and phlebotomists. Just a little bit about our phlebotomy department. Now, phlebotomists face some unique challenges. The way our department works, bloods are ordered on the electronic patient record system and are printed off in the phlebotomy department about 7:30 in the morning. Job lists are generated and the phlebotomists are allocated certain wards and patients they need to take bloods from. They would then go onto these wards, take the bloods, and in an ideal world, they would be able to register collection there and then. Unfortunately, the times they came on the ward were the busiest times when there were ward rounds and high demands for computers. For this reason, they were unable to wait around for a computer to be free and unable to register a collection. What this meant was there was a lack of real-time visibility. Any changes made by doctors or any changes made by phlebotomists would be unknown to the rest of the teams. Requests which were cancelled may not be picked up on, and patients were being bled unnecessarily. And there were unnecessary delays and confusion because doctors didn't know that patients had been bled, as phlebotomists would have to wait till the end of the day to register collection. Since we introduced the MCAs, the phlebotomists have been able to take these on the wards with them, as you can see in the picture there, to the bedside, take it to the patients, and check before bleeding the patient whether there had been any changes, additions, or cancellations. They were able to register straight away that the blood had been taken. And this has improved not only delays, but also improved productivity, efficiency, and patient experience. So that's been quite a success story for us with use by the phlebotomy. But as I alluded to earlier, we brought these in to help junior doctors. And we have been using it on the wards, not only to check and order results, but also on ward rounds. Now, as they mentioned before, these are very light, portable, mobile devices, which we can actually take to the bedside. Patients seem to prefer these as well, as it's much nicer to hold a small device in your hand and talk to a patient and check results there, rather than having a big laptop by your side and having to turn away all the time. So it makes for better communication with the patient as well. In addition, there are currently 2 means of input. There's a handwriting function which uses predictive text, and there's an on-screen keyboard which can be used by means of the stylus. So for shorter ward rounds, where there's not that much to type, we can actually use this, and myself, I have used this to great effect on ward rounds. Nurses also have used this because they find that a lot of their work is completing forms which uses drop-down boxes and checklists. These lend themselves to a stylus, and really nurses can use these and free up desktops for doctors to use for longer note typing and clerking patients. Other team members use these as well. And what we've found is, previously, people would type to a desktop. If a doctor was on one side of the ward and, say, a physiotherapist was reading a note on a desktop, and they had a question, they would leave their desktop, go to find a doctor, and by the time they had returned, guaranteed someone had stolen their laptop or desktop to use it for themselves. Now they can just take this with them or take it to the patient and ask the question. So people have really found that this improves